Janu Kanakar. He's our former chair of medicine, but he had the foresight I have a typewritten version of his proposal for a Center for Medical Genetics from back in the 1980s. And it's fascinating to think that he had that foresight to do that. And as part of that, we actually brought along Henry Lynch of Lynch syndrome, who became one of our first associate medical directors and helped us really get our Center for Medical Genetics started. But it was close to probably 2018, 2019, we really started to ask ourselves, why are we only focusing on such a small subset of patients that honestly typically are already disease burdened? They're just trying to find out the solution. And the question is, how do we get in front of that? And so that's really where our program has taken off and tried to shift from the reactive side of personalized medicine more into the proactive side. We've had over 400,000 to 500,000 of these surveys that have been taken, several 100,000 patients, because this is done every year, right? We've had over 55,000 patients. I think we're getting close to actually 60,000 patients who have completed genetic testing.
This is Genetics for Healthcare, a podcast for patients.
Welcome to another episode of Genetics for Healthcare, podcast dedicated to patients and their caregivers to help them advocate for precision medicine approach to their healthcare, which includes disease screening and prevention, treatment, and survivorship. You can find us at geneticsforhealthcare.com. From there, you can go to all of our social media channels. We got all the things, but connect with us and hit subscribe so you can get updates on incredible new content and episodes like this one. Today, we have Justin Brueck, Vice President of Innovation and Research for Endeavor Healthcare System. Justin, thank you for joining us.
Yeah, thanks for having me. It's great to be with you.
Now, just to clue the listeners in, like we met at Health, and I saw you speaking on a panel. And Health, for those who listen, go back to episodes 2021, 23, somewhere in there. But it's certainly the biggest meeting in the world in healthcare innovation. And you were on a panel with some of your colleagues talking about how your healthcare system has been innovative in this area of personalized medicine, precision medicine. But just give us a background on your healthcare system, the size, geography. Tell us about Endeavor Health.
Yeah, happy to do it. So, first of all, again, thanks for the opportunity to be here. Endeavor Health is a coming together of actually 3 or 4 legacy organizations in the last 3 or 4 years. And we now represent 9 hospitals, over 300 sites of care, almost close to 2,000 physicians that we employ, and then close to 28,000 or a little bit more employees. So it's a pretty large organization. We service an area of about 4.2 million patients on the northern suburbs of Chicago, and we serve, we have a catchment area of about 4.2 million patients, and I believe we serve around 1.4, 1.5 million of those patients. So it's a very large system, but we're just getting started with a lot of this exciting work and innovation. Thankfully, we have a history of genomics, which has given me an opportunity to go and tell our story and hopefully bring more of it to the masses.
Well, and that's how I kind of learned. And I went back and I watched some of your other videos that you talk about the innovation in your system. But give us kind of that backdrop of the history of Endeavor's innovation in this space of genetics.
Yeah, so it goes back quite a period of time. So, I will start by giving credit to who I consider the grandfather of personalized medicine genomics here at Endeavor, and this is Janu Kanakar. He's our former chair of medicine, but he had the foresight. I have a typewritten version of his proposal for a Center for Medical Genetics from back in the 1980s. And wow. It's fascinating to think that he had that foresight to do that. And as part of that, we actually brought along Henry Lynch of Lynch syndrome, who became one of our first associate medical directors and helped us really get our Center for Medical Genetics started. And so that was, late 80s, early 90s. And then in 97 or so, we decided to stand up our own molecular diagnostics lab with kind of a pioneer at the time, Dr. Karen Call, who serves currently as our chair of pathology. And since then, we've continued to focus on both medical genetics, being focused on kind of rare disease. But it was close to probably 2018, 2019, we really started to ask ourselves, why are we only focusing on such a small subset of patients that honestly typically are already disease burdened. They're just trying to find out the solution. And the question is, how do we get in front of that? And so that's really where our program has taken off and tried to shift from the reactive side of personalized medicine more into the proactive.
So I'm really appreciative of you having this conversation with us, because that's kind of the conundrum with the I don't know, we can call it a tidal wave of NGS tests, next generation sequencing, different types of genetic and genomic tests that are available, that can be overwhelming, not only to clinicians who practice every day, but to patients who may not know this terminology. But give us an idea of what kinds of tests you offer to patients, and how are you helping your clinicians understand the clinical use cases and implications of these tests?
I think it's a great question because part of this goes back to this notion that most clinicians spend more time in a cadaver lab than they do learning genomics and genetics. Yet, how often in practice are they dealing with cadavers versus having the ability to actually think about genetics? And so I think part of this stems back from the very fact that in our medical education systems, they still are focused on a lot of those traditional models. I think that's shifting now because genomics is, I think, finally hit mainstream in a lot of scientific circles and among societies in particular. But one of the things that we started with was we cannot try to teach all of our primary care doctors to be geneticists. It's just not possible. They don't have the time, they don't have the bandwidth, and to be honest with you, they don't need to know all that information. We've been fortunate to leverage a lot of really unique tools that we built within Epic. And as part of that, have something that we call our genetic wellness assessment that's now been taken hundreds of thousands of times by patients throughout our system. And it's part of our annual physical. Patients take this structured survey, pre-populated with family history if it's an Epic. And from that, the decision support actually tells the patient, tells the clinician, what is the right test that may make sense.
Okay, so let me double click on that, because you mentioned just now that how you've been able to systemize the screening, right? And you called it your genetic wellness assessment. We do have clinicians, we have industry professionals who listen to our podcast. And I guess the question, it's one thing to say, okay, you can order the test and make it available or make it easy. But how are you able to drive adoption of screening and offer testing at the primary point of care with that genetic wellness assessment?
Yeah, so I would say that it's even interesting how we got to the genetic and wellness assessment because we did this kind of crazy idea. We hosted an event in which we wanted to talk about personalized medicine. And we thought to ourselves, what are we going to do from an audience takeaway point of view, right? What are they going to get out of this that's going to be actionable? Because to your point, you can talk about it all day, but so many people talk about it, they publish on it, but we never see it actually translate. And so we had this random idea. Why don't we just put together a list of some of the common questions that our clinicians and genetic counselors, geneticists would be asking patients when they're looking at family history. And we just said, fill out this form. And if you have anything that looks like you have a high family history, meaning it was in a yes column, give us a call. And we had so many patients that called us saying like, hey, I have high risk family or high risk of cancer, or I think we also included cardiovascular disease at the time. And we said, this is something. And if we have this much energy and excitement from patients wanting to learn about this, how do you turn it to the masses? So that is the genetic and wellness assessment. It is part of every physical. So it's not an opt-in, opt-out by physician, practice by practice patient. It is part of every annual physical. And one of the things that we learned through the process, and you talk about adoption, we did this thing called DNA 1K, which was an opportunity for us to understand, what if we were to just give genetic testing out for free? Just give it to patients and do it as a research/clinical pilot. And what we found is that patients didn't want to have a genetic test offered to them when they're coming into immediate care. Why would they? They're coming in there for a very different condition. They're in a different mindset. And so what we ultimately realized is the best time to do this is catch people when they're already when they're already presenting to think about well-being. And that's part of their annual wellness exam or their annual physical. And so that in itself, I think, brings people in more of a preventative mindset. And then when we surface up that you have this potential risk factor, and honestly, a lot of our patients who have these risk factors have very small out of pocket because these are now like literally, I think we have most of our patients have less than $50 out of pocket, and most are free because as part of the ACA, There was actually some legislation passed that considered that BRCA testing for patients with family history met criteria that it should be covered as part of preventative screening. So most patients actually don't have any out of pocket. If they do, it's less than $50. So from our standpoint, it was just trying to figure out how do you turn the system on and get people excited about it, because it's one thing to get people tested. The next part is how do you activate them on those results?
Okay, so you're leading into my next question there. So first of all, I think that's phenomenal, and I really want other healthcare systems and folks that are in your role who are tasked with innovation and how to stand up a program, because you made it sound really simple. I know it wasn't simple, but you made it sound really simple. But you mentioned you get a patient tested. Um, what have you seen that when a patient tests positive for a high risk variant, what happens next? Because there's some follow up. There's some things that can or need to happen there. How are you finding that being able to close that care gap?
So one of the biggest concerns that primary care doctors had is, so you're going to have my patients that are going to be tested and consented for testing. I'm going to order the test, and then what am I going to do if they have a positive result? So very intentionally from the get-go, we said it that any patient that has a positive result will get outreach from our genetic counseling team. And it's a complimentary consult where they get to talk a little bit about it just to get any questions answered. We also allow the physicians, if they're comfortable, they can return the result to the patient. And what's been interesting, again, see one, do one, teach one. Over time, we've seen more and more clinicians that actually do that. So the number of times that our genetic counselors have to do that outreach has decreased. And I think there's something to be said about it's a genomic learning health system. You have to constantly be reinforcing this. But it comes down to, you have one patient, then you have two, then you have five, then you have 10. You start to understand what is the next best step. The other thing that we did, in addition to having those individuals that could help with triage and understanding patients' questions and things like that if they had a positive result, we established upwards of 10 genomic consult clinics. So these were clinics. Cardiology had 2 or 3 based off of different factors. We had neurology, we had prostate, we had breast, we had ovarian, we had cardiovascular. I think I said cardiovascular, neuro, all those. And the reality is, those became the relief valve because we knew that those clinicians were already ready and teed up to be able to see those patients. And we created visit types so that the clinicians knew when the patient was coming in what they were going to be seen for. So all of that kind of came together to make physicians feel confident that there was going to be a safety net if they needed to have their patient seen and they didn't really know what to do. And I think that's been our key to success, is always having someone there that can be available to support. Recognizing there's not enough genetic counselors in the world to be able to manage all of that, though, we had to get creative, and we created a brand new role called genetic counseling assistants. And these are individuals who are able to really take more of the formulaic, very predictable, very standard guideline-based recommendations and help coach patients through that. And they can always have someone who's there to escalate to the genetic counselor or to our geneticist. But those individuals have actually turned out to be really, really essential to our program, and fascinating enough, it's actually become a pipeline into our genetic counseling program because they're like, hey, I could go to school and get a master's degree, and now I can actually do this genetic counseling on my own. So it's been a really exciting program, and I think it'll be a key to our success as we continue to scale across the broader system.
20 years ago, and I've spoken to different folks, Robert Green at Harvard, who runs the All of Us, or excuse me, the Baby Seek, projects. And 20 years ago, the concern was when you're developing these these genetic tests was to prove that people actually wanted this information. There was the concern that it would cause angst, anxiety, unnecessary worry for things that you test positive for a gene variant, and there might be a misunderstanding that that variant may be causative, and it's not causative. Just because you have an expression of a gene variant or a mutation doesn't mean you're going to have or develop a disease. But in your rollout of your program, how have patients received the testing program? Have you been able to monitor, how they perceive it? Is it welcome? And for that matter, for those who have a positive finding and need to follow up, how has it been getting them back into the clinic to counsel them?
Yeah, so I would tell you, first of all, that we have several publications, and I'm happy to send you them, and maybe you can link to them on your page, because we
Mm.
did look at that. We looked at patients' anxiety before getting the test afterwards, if it was positive or negative, and then we followed them, I think 6 months and 12 months later. Don't quote me on that. But we wanted to understand, like, was this actually creating anxiety? And yes, there was a blip, but then pretty soon it started to taper off. And I think that is something that's critically important. We also deal with the fact that a lot of individuals are concerned about what does this mean from privacy and protection and life insurance and things like that. And it was one of our clinicians that kind of said this, and I know it's maybe a little bit blunt, but they said, you can have really great life insurance or you can live. What do you want? And it was a tagline that kind of, it hits home. But there were a lot of people who were like, you're right. Like, if I have the ability to know this information, it could save my life as opposed to having a really great life insurance policy. And so we've tried to figure out how to massage that. We've had a variety of uptake across different geographies, different ethnicities. And so another paper that I can share with you is some work that we did with our Vietnamese community in one of our safety net hospitals. Because as we've talked about it, genomics has the ability to become something that furthers the divide. And genomic exceptionalism is something that we really are concerned about. Like, we want everybody to have access to this. And so when we saw that there were differing rates, we wanted to know why. And so we sent a genetic counselor into there that's one of our research genetic counselors. And she did an amazing job of engaging with the community, finding out, like, what are the words that we need to use to describe this? Who are the influential thought leaders that your patients are listening to? It turns out it wasn't our system. It wasn't the flyers that we were putting out there. It was a pharmacist on the corner who had been in their communities for decades. And that became a trusted voice. And so we had to think creatively about how do we start to bring this along? Because again, if you're solving for only one portion of your population, you're going to create further disparities. And that's something that, from an income standpoint, from an ethnicity standpoint, we were really committed to solving.
That's phenomenal. A way to approach that and thinking. So yes, I would love those links to those studies because we will put them on the episode page at geneticsforhealthcare.com. You mentioned the way that you structured to staff the program, because these are a lot of folks getting screened. And for many other healthcare systems, what we find is a huge logjam of people that need to meet with a genetic counselor. And um, you've certainly seemed to solve the workflow, the patient journey in your healthcare system. But what's typical is if a patient is diagnosed with, let's say, a cancer, they're referred to genetic counseling. Or if someone is, as a family member that's been diagnosed, they send them to genetic counseling. Well, that genetic counselor appointment could be anywhere 6 months more, right? How did you guys address, and what does your staff look like to be able to handle this type of patient volume that need consultation?
Yeah. So if I told you this, you'd probably follow your share, but let's go with it. So we have one geneticist for our entire
Sure.
and when you think about that, it's like, how do you manage 1.4 million patients with a single geneticist? And it's, you have to have those other care providers. So we have, I think, 6 to 8 genetic counselors. But if you look at that, some systems that are much smaller than us have many more genetic counselors. And what we decided is we really had to lean into technology. We needed to lean into primary care doctors, and we needed to lean into these genetic counseling assistants. And so one of the things that I find really interesting, and again, part of this is maybe a bit provocative, maybe controversial, what I'm going to say, but that's what podcasts are for, right? You know,
Yep.
you have to look at the history of why genetic testing kind of came along, and the structures that we created behind it, and the requirements from insurance and all these things. When you're looking at that, tens of thousands of dollars for genetic test, insurers don't want that to be offered to everybody without any reason. And so for me, this was kind of an aha moment for us. It's like, well, if you know the criteria that the insurers want, you don't need to go through all the rigmarole of having all these additional visits and what have you. And so what we did is we built our documentation and our questionnaires to be guideline based. So the question around access, patients who are getting genetic testing from primary care do not see a genetic counselor. They get informed consent. We have videos that they have to attest to understanding. There's some teach back in there. And ultimately, from that experience, they have the ability to go to a lab, have their tests drawn, and then ultimately get the results. And they may never have talked to a genetic counselor. They may ultimately talk to their physician or to a genetic counseling assistant, depending on the mutation. I think that is a mind shift. So when I sit down in different panels, you get some individuals that are like, that's bad medicine. That's it. And I think about this. we today in genetics go through more consenting for something that is only a risk factor, getting back to your point, like, than we do for things that can actually be extremely life altering. I mean, you could get a simple blood test for a cardiovascular marker and it could change your life, right? Or a white blood cell count or something, right? Those could be life changing. And yet we don't counsel patients saying, hey, there's a chance that you're could be off, and as a result, you may have cancer. Yet for genetics, we've done that. And I think that's where we need to evolve this. And I do think that technology, I'm going to say the word AI, all of these things are going to help us demystify genetics in order to kind of help patients along. And I think, honestly, from an insurance standpoint, the cost of testing now has gotten so affordable. There's actually studies that are coming out saying that the quality adjusted life years for someone who has a family history of breast cancer, it's equivalent to a mammogram. And when you think about the cost of a genetic test. And so that to me is starting to develop the health economics outcomes that are going to ultimately, I think, push genetic testing to be even more adopted, because we're shifting into a world where we have to be focused on value and not volume. And the only way to do that is to understand risk.
Justin, you know this, but on the many panels and the places that you go to talk about your program, there are many of your colleagues or healthcare systems that are standing these up. And hey, they're the early adopters. They're building these programs. But you guys have been innovators and you've got outcomes to speak of. Can you talk about the impact of this program that you've enrolled in terms of the number of patients tested and served and what has been the downstream impact of improvement?
So as mentioned, we have now actually in the last, I think, 5 years tested more patients than we had in the past 30. And that is something that's directly associated with the genetic and wellness assessment. And as I mentioned before, we've had over 400,000 to 500,000 of these surveys that have been taken, several 100,000 patients, because this is done every year, right? We've had over 55,000 patients. I think we're getting close to actually 60,000 patients who have completed genetic testing. And you think about that, 60,000 sounds like a really big number, and it is for a system, and we're really proud of that. But I just said we have 1.4 million patients. We have 1.4 million patients at our current rate, and we have probably 100 to 200 patients that are getting genetic testing every week. It would take us 80 to 100 years to be able to get everybody where they needed to be. And that's just too long. And so for us, we're really trying to think about what do we need to do to add a zero to it. And a lot of it's going to come in through activation and things like that. But it's, to your point, showing the outcomes to the clinicians. So typically we see anywhere from a positivity rate of 3 to 5%. But we also added pharmacogenomics to a lot of our testing. And so for our population panels, for example, we now have the ability to share back pharmacogenomics reports that are built in with clinical decision support in Epic. And 99% of patients have at least one actionable finding from that. So you're giving value back, and it's something that I think, as clinicians start to see it, they start to understand, yes, this should be part of standard of care. What's been really exciting for me as I think about the potential and what's next, we have now rolled out a lot of ambient solutions for documentation. And with that, we're actually seeing providers that are saying, I have some free time. And so one of the things that our team is really excited to say is, with all these new technologies that are freeing up providers' time, are they able to actually engage and move the needle when it comes to some of these other technologies like wearables or genomics, or things that are really going to help us identify signal before we have disease. So I'm super excited about what that potential may bring for us.
And everything you're talking about is pushing towards the promise of precision medicine, not just to improve outcomes with chronic diseases like cancer, sickle cell, heart disease, diabetes, all the things that we're applying this genetic and genomic approach to. But if you future pace this approach, have you guys thought about the financial impact that will be not only for patients, but for the healthcare system?
I mean, the first thing that I would say is that we have been very committed to this is guideline-based. We want patients to be accessing this information that makes sense, and then we follow the guidelines relative to that. And to the point, you're identifying a patient population that's has not experienced disease yet. So yes, they're more likely to be commercial as opposed to Medicare. And as a result, those have different payer dynamics and different reimbursement associated with those follow-up procedures. So yes, there is a contribution margin and business case to be made about saying, how do you identify patients at an earlier phase and have them move through the system, because it does. You have a positive BRCA mutation, you're going to have some different options. You could go down a path that's more screening, and so you're going to be adding MRI or ABIS or something like that. So there's additional procedures there. Or you may take a more aggressive, if you're past childbearing years or something like that, you may have an oophorectomy, hysterectomy, double mastectomy, plastics, all these different things. And again, deeply personal decisions that people are making. But it's the right thing to do clinically. There's standards that we're following. And yes, as a healthcare delivery system, there is a business case associated with doing that. But that to me is a secondary point. What I really am excited about when I think about what we're doing now is, in the future, we are going to be taking on more risk. We are going to be taking on capitated risk. And I keep thinking about, like, every patient that we activate today is a patient that hopefully we've reduced their risk profile in the future. So it's good for them because we've reduced that risk. And then for us as an organization, assuming that that patient is part of our system moving forward, we've actually had the ability to proactively bend that cost curve that may have resulted in stage 3 diagnosis of breast cancer, stage 4 diagnosis. And to me, that's really what's exciting when you think about being able to scale genomics to entire populations, is now you can almost imagine a world where genomics may be what ushers us into a value-based care world.
Justin, you're laying some gems out there, and listen, I know I'm a precision medicine geek, and many people who listen to this are precision medicine geeks. But this is really good stuff, and I appreciate your efforts to do it, and I love hearing about it, quite frankly, because we want to put this out there. Now, I always ask guests or patients or people that come on the show because at the end of the day, innovation means nothing if people, patients, can't access it. And so I love to ask our guests for 3 practical tips. But because you're here and you've laid a lot of things on us, I'm going to ask you 2 variations of this question. The first is, what are 3 practical tips that someone that may be your colleague that has this vision or wants to champion building a precision medicine personalized health program, and you got to have allies, right, to for the investment and for the effort. Someone's thinking about creating this type of program. What are 3 practical tips that you would give them? And secondly, for patients, for someone who wants to get genetic testing as a health screen, but they don't know how to go about it. They've never been offered it in their healthcare system or their annual checkups. I know this is kind of loaded stuff. So,
I'll take the last question first, and that's very simple. Just choose to have your primary care provided at Endeavor Health, and we'll make sure that you get your genetics.
Right.
Seriously, though, I mean, I do think that there is a movement where patients are becoming their own healthcare CEOs, right? We hear that comment a lot. But this is truly the opportunity where patients will have the ability to ask the questions. There are also a lot of services online, and not suggesting that that's something that people want to do, but you can go online and you can find doctors and different clinics that are willing to refer you into those types of organizations. I wish that we could offer genetic testing across the entire country. If you're in the state of Illinois, we can help you out. But I think it's really having a patient be really informed. And that's unfortunate because not every patient is listening to your podcast, even though I'm sure you would love it. I think there's an education piece that's going to have to go along with it as well. But there are a lot of different options out there. Other things that people can do is see if there's a research study that's going on in their community. Like, sometimes the easiest thing to do is join one of these large research consortiums that are doing these genomic biorepositories. That's actually how we got started with some of our activities. Is we launched our genomic health initiative, and now we have 80-some thousand patients that are in that. And as part of that, we return results, and they're actionable results, and there's no cost to patients. So those would be 2 practical things that I would say for patients: is look to research, and then do your own healthcare CEO exploration and see what is available in your communities. For health systems that are looking to get started, I would say, if you're going to be successful in this space, you cannot start the way that it was built originally, because there are not enough geneticists, there are not enough genetic counselors, and there's not enough geneticists, genetic counseling assistants even in the market to be able to build this in the way that we used to practice. I think it's trying to understand, what are you solving for? We talk a lot about our pyramid model, which is, you have at the very top of the pyramid rare disease, very few patients that are going to be in that category, versus as a community-based. So that may be more of an academic medical center or a specialty hospital. versus us, we focus more on the bottom of the pyramid, which is where you see the ability to impact populations. So one of my practical, questions to the group would be is, what patient population are you solving for? Are you solving for rare disease? Are you solving for population? And do you have any centers of excellence that could actually help manage the downstream associated with that? Because as I've said all along, it's one thing to get somebody tested. That's actually the easy part. I mean, it's complicated, but it's easy. What's hard is to figure out how you activate them and keep them on the care pathway. So you have to make sure you're not just filling the funnel. You got to make sure that you have the funnel that flows all the way through.
Fascinating information. Justin Brueck, Vice President of Innovation and Research at Endeavor Health, delivering on the promise of precision medicine. Thank you for being a guest on Genetics for Healthcare, because I know you got a demanding email inbox that will not leave you alone. So
my apologies.
No worries at all. I really appreciate you coming on and sharing what you guys are doing and the impact that you're having on patients. Thank you.
Absolutely. Thanks, Rob.